Hello, everyone. We are in the courtroom once again today because we're going to be discussing the case of the Commonwealth of Kentucky versus Yvette Hunter, a nurse. Well, she's not a nurse anymore. She was a nurse, and she administered a nursing dose to her patient who was 97 years old. She gave him Ativan, and it then caused unknown situations, which we will look into today, but they may have been linked to what ultimately caused him to pass away 5 days later of aspiration pneumonia, which is when you, instead of breathing air into your lungs, you unfortunately breathe food or liquid into your lungs. It's not great. We're going to be looking at what exactly happened here, discussing different aspects of the case and how it was reported, and just chat about things in general related to it, what you can do to avoid situations like this. And we're going to talk about the nurse dose, which is always a hot topic in the healthcare world. Ready, set, and let's go. Oh, once again, I forgot. One day I will get all of the moving parts of a live stream going well, and it will be a wonderful day. If you are here live, welcome, welcome. I am Liz. I'm a family nurse practitioner. If you're new, hello. We see lots and lots of friends in the chat. Thank you for being here. If you're watching on the replay, there will hopefully be timestamps. Eventually, one day, we'll get there if you want to skip to certain parts that are interesting to you. But I think this whole thing will hopefully stay fairly condensed, and then we can have a little bit of a chat here. We already have some warnings coming in. Mr. Midwife says you're not going to like what I have to say here. Oh boy, that's an excellent cliffhanger. We should title, that's how you should title your YouTube videos, Chad, is you're not going to like what I'm having to say here. CK Medics says, I actually don't know anything up front about this case. Also, thanks for being a channel member. Court of Public Opinion is in session. Yes, and welcome. And let us see, we can do a poll about that really quick. Do you know anything about this case? Have you ever heard about this case? Is it even a question if you don't sing it? No, I don't think so. How are we all doing today? Let us know where you're watching from. Someone congratulate. Someone needs to congratulate me. This is my first time I've ever been on time to one of my own lives. Please let me know. And we have, hopefully it's not choppy. We have some people saying it was choppy. Chris Fleming. Hi, Liz. So glad I got to make a live stream for the first time in a while. Hello, Chris. We have Rogue NP. Hello, Aaron. I saw Lisa. Hello. We have a whole crew. Mama Nurse. Excellent to see you. And Kate. 90, Meador, 97, dude. We're going to be talking about different things within there. But I do want to just come out and say, I've seen a lot of things on TikTok saying like, he's already 97. We do not endorse doing nasty, doing things to people that are not safe. Even if they are 97, you are still 97. Does not necessarily mean, that does not mean you get less care. And Rogue, hello. Okay. So, we missed you on Sunday, Liz. Oh, thanks. I know Scott's not here. He's probably not used to me being on time, or he might be. He's probably studying. The patho life is getting him caught. If you're confused, these are other people who round out our beautiful panel normally. And on Tuesdays, I talk at everyone, and on Fridays, we have a whole panel discussion. Sunday, we had a busy weekend. We had our neighborhood community party where we, got to meet a lot of our new neighbors because we live in a new neighborhood, which was great, but I was so peopled out. I am very I'm fine with going out and socializing, but I'm an introvert in that I don't gain energy from being around people, you know what I mean? And I just needed to not to. I was like, I need to not talk to people. I just need to chill. Lisa Caprone says he was 97 and a veteran from both World War II and Korean War. He deserves better than this. I looked up after seeing the upcoming live topic. Absolutely. No one deserves to have a incorrect medicine given to them and be treated this way. This is just not ideal. Okay, so let us dive right in and take a look at what we are even talking about here. Okay, so we have unsure. I never know when I pull up these articles. I'm like, I don't know if this was the best well-rounded, I felt, article I could find on this. But even then, it says some very interesting things, which we will talk about. And I do want to just say that the whole point of us talking about this is to highlight what we can do differently, gain hopefully some clarity on a topic that is swirling around social media, and there's lots of information that's not so correct out there, and just bring things to light so that if they're in the light, then hopefully they won't happen again. We can create help other people from making similar mistakes, and we can just make the world of healthcare better overall. Huge condolences to this person's family. Obviously, all of these cases that we talk about, whenever someone gets harmed, I'm going to avoid using their name as much as possible because that's not how I want it to be like remembered. Obviously, this person has done a lot of great things in their life, so we can remember them for those and not necessarily the really unfortunate situations regarding their death, which is truly, truly tragic. That it had to end with any, you never want, if you have a loved one pass away, I just can't imagine having it have these other swirling things surrounding it. Here's our news article. A former nurse in Lexington, Kentucky has been charged with murder after she allegedly committed intentional medical maltreatment of a 97-year-old patient, according to the Lexington police and court records. So this is right out of the gate saying a lot, right? So if you are being charged with murder, especially in the state of Kentucky, that means that you had intent, you had malice, you had something where this was your intended outcome. So right away, I am unsure if going into this, if this is the right way to approach it. Obviously, this is the court of public opinion. I'm not a lawyer. I am a nurse practitioner. I was a bedside nurse for 6 years. But I think if this case does go forward, I think they'll have to lower that to not a misdemeanor, to like a homicide charge of like negligent homicide or something like that, where you do something, it was really bad, but it's not you going in. I don't think, spoilers, that this nurse had the intention to kill this patient. I think that happened, and it is very manslaughter. Thank you to 18 nursing. I was like, there's a better word for this. Negligent, like homicide or manslaughter, which is where you don't intend to kill them, but they died. So still very serious, but the intent is not there. But they are currently pursuing murder. Eyvette Hunter is the previous nurse's name. She's 52, was indicted on one charge of murder and arrested on Tuesday, according to the court reports. Police say Hunter's maltreatment caused the death of James Morris, who died at Baptist Health in Lexington, Kentucky on May 5th. And this is all coming to head right now because they just recently had the hearing with the Board of Nursing, and then with the case where they presented it, and she came out and she said, she was pleading not guilty. If you don't know anything about the court of law, it is very slow. It is slow moving. So that's why we're just discussing this now. Police say an investigation determined that Hunter committed the maltreatment 5 days prior to Morris's death. So the event happened, and then 5 days later, the patient passed away. She was also going to be viewed by the Board of Nursing. We will look at that document, but I thought this summarized it well first. According to a suspension order written by the State Board of Nursing, Morris was aggressive. So Morris is the patient. So the patient was aggressive and agitated while in the hospital, and he was hospitalized for a slip and fall accident. So I don't know where he was before then, but it sounds like he came into the hospital, probably hit his head, maybe had some other injury, because he had fallen, came in, and he was really agitated and upset. It was I think it was nighttime. Was it nighttime? I don't even know the timeline of that, but I think we've all had a lot of patients who have been admitted to the hospital, agitated, really, really, it's easy to get confused in the hospital because we don't let anyone sleep. And it is a perfect combination for delirium, which is when you aren't quite sure what is happening around you, particularly when you are 97, right? The older people get, they tend to be more at risk for things like that. When the nurse asked the healthcare provider on the team for something to help calm the patient down, the healthcare provider said no. Now, from my standpoint looking at it, this is a difficult balancing act. This is like just side conversation, by the way. This isn't like, doesn't justify what she did or anything like that. They probably said no, because medicines that usually calm your patients down also have side effects of like sedation, usually. So if you're asking for that and those medicines that cause sedation also usually require your kidneys to be working pretty well, because they are going to be poorer at processing the medicine. So basically your kidney's like a filter. It shoves medicine through it. And the older you get, the worse your filter gets, right? So the medicine circulates in your body a lot longer. Normally, if you take, let's say, Ativan in this situation, because that's what we're working with, your body processes it, you're sedated, and then you kind of come out of it and your body's able to like deal with it and go away. Uh, in this situation, if your kidney filter isn't working, it would just keep circulating and circulating and circulating. Then obviously it's going to cause more sedation. It can also just be more dangerous for these patients. He's obviously in there for a head injury in the first place, which makes you think, I don't want to give him anything he already has altered mental status. Who knows if it's from his fall? So I don't want to give him more of something that might also cause him altered mental status. Also, Ativan makes you confused, can make you confused, particularly when you are in your 90s. It really, if you're over 70, it can start to make you confused. And yikes. So I probably, as a nurse practitioner, also would have said, ooh, no, I don't have a great other solution. This is, again, a situation where we're like, I don't know. It's unfortunate that you are in this situation where you have to take care of this patient who is now agitated and confused, making it so that you can't really take care of other people. But chat, let me know if you like, would you have also, if you're a healthcare provider, like written the meds for them? Because I'm saying no, like this makes me nervous because of this situation. And this is a reality of working at the bedside of nursing, is there aren't enough people to keep our patients safe, right? So this nurse is in a tricky situation because she has an agitated patient. She probably doesn't have anyone to sit with the patient. The patient's trying to get up and out of bed. You don't want them to fall again. That's why they're in the hospital. The provider's in a tough situation because they're like, I can't medically calm them down because I don't want side effects to happen. So that's a little bit of our situation. Just like Mr. Midwife said, no GFR, which is your glomerular filtration rate, which is your kidney. No meds. Exactly. If your kidney's not working, we can't give you any meds. Really, it's just a difficult situation on all ends. So that's kind of the picture of what we're walking into. And someone else had said, that I think Lisa said, I also read that both the physician and the nurse practitioner had been asked for an order of lorazepam, which is Ativan, which would make you calm down a little bit. It's for like anxiety. It's a benzodiazepine. So when you hear of people taking, like popping a pill to have their anxiety calm down really quick, it might be one of these. And they said no, because they were probably like, this patient, of all the reasons we talked about, they're confused. We don't want to make them more confused. We don't want them to fall again. We don't want they probably don't have kidney function. So let's just not do this. That makes it even more egregious too. Yeah. So it makes it, I agree that what happens even worse because you directly asked for permission and then we're told no. The nurse then allegedly withdrew a vial of lorazepam, which is the medicine she had asked for, Ativan, meant for another patient. So this person then went to the chart and said, hey, I can't get an order for this. And so I have this other patient that has the order for Ativan. And she drew that up instead, because that was a different, you have to, when you go to get a medicine out of controlled substances, which is what Ativan is locked up in like a medicine cabinet type computer thing. And you have to scan get into it, whether you're scanning a fingerprint or typing in your password, you get in there and you have to pull it out by patient. So you can't just go in, and it would definitely look sketchy if she went in and like overrode it completely. So she went in, she used this other patient to get into the machine, pulled out the lorazepam for the other patient, and then appeared to go into the room with a syringe. All of this is alleged because this case has not been like solidly, like they haven't tried it yet. So all of this is alleged, not like stated as fact. Proceeded to administer something intravenously into the patient. We're assuming that it is the Ativan that she had pulled out of the Omnicell. And after that, Morris became sedated. Lorazepam is used to relieve anxiety, according to the National Library of Medicine. This is what I thought was just kind of like, Interesting. It is intended to work by slowing brain activity. That's not how that works. So at all. So lorazepam is a benzodiazepine. It works just by it inhibits some receptors in your brain called GABA, and it basically just tells your body like you don't need to worry about that. It doesn't slow your brain down. I just thought that was a very interesting way. Slowing brain activity. It doesn't slow brain activity. It just kind of reroutes it and it bypasses the part of your brain that's like, I'm being eaten by a bear, which is causing you to be anxious and agitated. And it's like, you're on a beach. Everything is great. You are worried about absolutely nothing. And there we are. And limbic system said, this looks bad. This is bad. This is not a case where we're like, oh, what she did is fine. This is more of like, please don't do this ever. This is not good. J. Michael says too many risks with psychotropics and gerontology. So that's pretty much any med you're going to be giving a patient that is going to change their agitation level. It's going to be a psychotropic. And in gerontology or older patients, all of those are very difficult because of your kidneys not functioning as well. It makes it very difficult when they're agitated. What alternatives were used? Sitter, family? Don't know. That'll probably come out in the trial. It doesn't sound like they had family there, and it makes it, like I said, this is a difficult situation that we had all the time when I was a bedside nurse, where your patient's agitated, they're older, they're delirious, you don't have a sitter. And you're like, what am I supposed to do? You can't restrain them because you can't get restraints are obviously physical restraints are never great. It's a mess. That weird science guy said, I can see where this nurse is coming from, but it's really bad not to listen to the provider and go behind their back and administer the patient medication for a different patient. Agreed. I think we can all agree on that. It's a lot. So basically where we are right now, patient agitated, nurse asked for meds from physician and nurse practitioner, I believe. And she said, can I have something to calm this person down? They said, no, we aren't into here's the reasons why. And then she went and pulled it from a different patient and gave it to the patient. So not ideal. We're not loving where this is so far. Let me see. 82% of you, can we close this? Yes. No. So 82% of you have not heard about this case. I imagine that means you're probably not on TikTok, which is good for your mental health and good for you because this is like all over there. Another hospital employee saw what happened and asked Hunter what she gave the patient. Hunter answered something special. The Board of Nursing Order says, again, allegedly, the patient was then found with, so one thing that lorazepam does, as a side note, in case you are not familiar with that medicine, is part of the part that tells it like, hey, you're not fighting a bear, you're just chilling on the beach. It just makes you sedated a little bit. You're sleepy, you're groggy. This is one of those that on the label, it would say, don't drive a car, don't do X, Y, and Z. Like be at home, make sure you're not doing anything like this. Anything that could be dangerous and your thinking might not be clear. We don't like to do things generally like give it to our patients and then not monitor them fairly closely, right? Especially if they're older, if their kidneys aren't working, because again, the effects could be greater. And so it sounds like, though, this person was later found with, they came back in, they checked on them, and they found with the patient had labored breathing and their oxygen saturation equipment was turned off. So they did have a finger pulse ox on, it sounds like, which would measure your oxygen, which would tell you, hey, how much blood is getting to your brain and your other organs. We want that number to usually be like 97 to 100. In a 90-year-old, someone in the 90s, I would really take anything above 90. I'd be like, hey, that's great. Yay, we're here. But they had turned it off. So that would be like the one you would want to leave that on. So you would know, hey, is my patient having difficulty breathing? It was determined that and labored breathing is just like they're working hard, which would be, that's not good. We gave you a medicine that's going to make you kind of sedated and have to work really hard. And now all of a sudden you are working really hard at breathing. We do not want that. It was determined that respondent had disarmed or lowered the oxygen monitor several times as to not set off the alarm at the bedside. So we don't know who the respondent was, do we? I don't think it says. Like whoever had come and answered the call light had taken the pulse ox and noticed like, why does this keep alarming? Because when your vital signs alarm machine goes off, you're also going to have like it's going to alarm to the nurse's station or wherever or to your phone. And they kept lowering it. And then they turned it off because it was probably alarming a bunch. This is something, don't do this. Don't do this. uh, it can be very, very annoying. And like, I get it. It can, we have a lot of alarms in healthcare, right? Healthcare alarm fatigue is a very, very real thing. Oh, okay. Thanks, J. Michael. Respondent would be the nurse. She was the respondent to the board complaint. Perfect. I was like, I don't know who that is. So the nurse came and turned off the oxygen monitoring system. Probably because it was beeping because her patient was not breathing overly well. Don't do that. I will say that we do change, like just to be totally frank, we do change a lot of alarms in healthcare. Having worked on a cardiac unit, I have set some interesting alarm limits because sometimes you are like, I just need this to, like, I'm aware of the situation. I know this is funky. So I am going to, like adjust this, but never just adjust it and then like abandon ship, right? It's more of like, I'm watching this really closely, but if this beeps at me one more time, I might smash the monitor. But you never just like totally turn it off, right? Unless the patient doesn't need it. Also, this is stupid because there's way to silence a monitor in a patient's room so that it doesn't beep in the room. It just beeps outside of the room, So you can adjust monitors, you can change where they're beeping, but if it's beeping, you should probably investigate why is it beeping, right? Why is it telling me that their oxygen is too low? This is this is not a good situation. Also, Jay Michael, thanks for becoming a new member. I appreciate your support of the channel. Interesting. So Renee Poestner said alarm limits are typically set by the unit. We were never allowed to change them. That's interesting. We always could change it because you never know what people's what you actually want it to be. So, and yes, the Vanodyne alarm can get annoying. There are a lot of alarms in the hospital. And so I know even like, and I'm not saying this to justify it. I'm just saying it of like, I can imagine a situation where someone would be like, I know this is happening. Okay. Just like, I just need to turn this off. It is a problem in healthcare that we have so many alarms, but just shutting them off, don't do that. Don't just shut the alarm off, especially when it's for your oxygen. You know what I mean? Like, I hear you. I get it. I can see how all of these things happened because, again, I can see this nurse being like, this is really, I have nothing else to do. Like, I am desperate. They keep getting out of bed. They're going to fall, blah, blah, blah. I'm just going to give this. Who's going to find out? Oh, no, they're not breathing so great. I'm sure it's fine. They're just asleep. Let's let their vitals dip a little bit while they're sleeping. Maybe it happens all the time, right? And obviously this is conjecture and everything. I'm just showing you how you can kind of maybe think about it, but not good. Please do not take your patients off of the monitor like this. Okay. Not good. The document indicates that Morris had aspirated food or medicine given to them. Aspirated is when instead of breathing air into your lungs, you are breathing liquid or food or a different item. That's not good. Your lungs don't like that. It's not good. As a result of the incident, he developed pneumonia, according to the Board of Nursing. Morris went to hospice care on May 3rd and died 2 days later. So it sounds like this event kind of started what was otherwise a hospital stay that was going like, okay, and then went downhill. I have some questions. We'll go forward and then I do have different questions. We'll get to this. Despite the rapidly declining condition of the patient, the nurse never called for a rapid response nor acted with any sense of urgency, the Board of Nursing stated. A respondent did, however, edit documentation of administered Ativan on patient B to state not given. So she pulled the medicine from the other patient, which I don't know why you would do this. Like, I think she wanted to make it look like none of this was happening. Pulled it, gave it, then marked in the other patient's chart, oh, I never gave it. Clearly, it seems to have been given. I have questions here because usually if you say not given, you would also have to witness the waste to be able to go through and say, hey, I actually didn't give this. And then this person saw me squirt it out into wherever you squirt it out into. We used kitty litter. I don't know what other hospitals use, to say, obvious, like I didn't do anything else with this, like give it to my other patient. So I don't know how she got through that. We aren't allowed to like, I guess you could waste it or like could mark not given without showing a waste, but not good. What are you going to say about it? I feel like it's just gone. The only thing I have questions about here is, was the patient like a DNR? Was a patient, because if they're a DNR, do not resuscitate, there may not be urgency in terms of a rapid response. And that could be a reason why a rapid response would not be called, would be if no interventions were requested like at all. I could see how that would maybe change it, but I don't know if there was a DNR in place. That's the only reason I could think of why you wouldn't escalate the condition when your patient's not breathing. Police began investigating, and the case was referred to the police. So that is kind of the overall, the gist in terms of what is happening here. She's currently in jail. She has a hearing, or she had a hearing where she came in and she pled not guilty to murder. And the next court hearing is, when did I find it? In November, I believe, is when her next court hearing is. Let us take a look now at the, so in a nutshell, and then we'll take a look at the Board of Nursing actual complaint. But I thought this summarized it really well, especially if you're not a nurse. This summarized it really well. And then we can kind of go through some of the key facts that they found in the actual nursing report. But if you have any questions, if you have any thoughts, my thoughts are, this is not good. This is awful. You do not get told, no, you can't do this, and then take matters into your own hands and apply vigilante justice and decide, I'm going to take this medicine, pull it out from a different patient, administer it to my patient, and then turn off all the alarms. Do I think she did it with the intention of killing him? No. I think she probably felt desperate. Like, I don't know what else to do. In my mind, this will fix it, and then did it and was just trying to make him calm down. She ended up feeding him afterwards. I think she was just trying to care for him in a very misguided way and did not think that she would end up getting caught in this way, if that makes sense. Hold. Must drink. So that's kind of where we are right now. Let me know what you're thinking so far. Exactly. Critical thinking skills. And I also don't know how desperate this person was, and that doesn't just like say it's okay. It's not okay. But just trying to get into their head and think like, why would this occur to you? If you have 7 or 8 patients and one of them is someone who's in there for a fall, they keep getting out of bed, they're agitated, you don't have anyone to be with them. I'm just saying, I can understand the desperation to want to just do something to fix it. So that's kind of like a huge flaw in our healthcare system at the moment. But yikes. Yikes. Don't do this. Not good. Not good. I have never heard of something like this happen. So I also don't want you sitting out there thinking like, wow, this happens all the time. No, that's why it's in the news. It's because it's like, ooh. Candid Ann says, I'm also an RN. Restraints are the last option, but sometimes necessary for patient safety. A soma belt, a laugh belt, soft mitt, something. Agreed. Physical restraints, we don't want to do them, but it would be better than going and stealing your neighbor's medicine and administering it and then having aspiration pneumonia. That leads to death. That's definitely never good. J. Michael RN says, so diversion, falsification of records, time 2, willful disregard, violation of physician's orders, practicing outside of scope without appropriate license. Yes, this was not good. This is not good. CK Medic, a lot of things she did surrounding the administration of the Ativan sounds like they will go towards intent, falsifying documentation, disabling monitoring equipment, diverting a controlled drug. It will be very interesting to see. I would say that that's an intent to, I don't know. I think the way they wrote, by saying it's murder, I think is a very bold choice, to be totally honest, in going after it, because murder would imply I want you to die, right? I want this to be a lethal action versus I don't think she wanted it to be lethal. I thought in my mind, obviously we don't know, I'm not her. I would think that in her mind, she just wanted them to calm down. You know what I mean? Let me know what you guys think in the chat. But Mama Nurse, absolutely wrong move completely. This is not how you handle this situation. In this situation, you go up the chain, right? I think someone had said, like, tell your charge nurse. Yeah, tell your charge nurse, be like, this is out of my hands. Like, this situation is going to become dangerous. That is when you just have to start documenting, like, I did not have, you know, I did not have a way to keep this patient like safe. That's when you start looking for other things, restraints. Someone said a jerry chair, things where like, and it sucks. This is when we start getting into like physical restraints. How can we keep the patient in the bed and safe? And Lola says, like this point too, medication can be used as a restraint as well. Yeah. And so they had denied that. Lisa Capron said a lot of places won't allow jerry chairs to be used in that way. I think the unintended consequences of the restraint regulations are a real issue, but there were problems too. So jerry chairs, you kind of like strap them to a chair and then tie them to the chair. You can have a lot of injuries with that. Yes. It's just, it's sad that she felt this was her only or best option. Who said Kate? I agree. I think this is a sign of desperation. It doesn't make it okay, but OB Nurse Chelsea, this is an example of a fatal med error where I won't stick my neck out and defend the nurse. Definitely. I don't think what she did was right. I think we can just use it as a point to try and understand where she I want to point out that what she did was incredibly wrong and not justified, but also point out that like, this is what is happening in a healthcare system that is so overworked like it is I think things like this are going to keep happening because people are so desperate. You know, if it's you, go up the chain of command, document, hey, I can't get a sitter. I can't get this. I asked for a different interventions. They said no. I told my charge nurse, we don't have anyone else to pull to sit with this person. We don't have a like X, Y, and Z. Providers are informed. This is the situation, and when something very unfortunate happens, that's what happened. Like it happens, but it's documented. Do not create this other way of fixing the situation. There's apparently a series on Amazon Prime. Lots of cases similar to this, very sad. Not good. So, can you put Rogue what the series was called? And see. Aaron says, I agree. It seems she didn't intend to murder the patient, but definitely a series of poor choices. Yeah. And there's a lot of other charges for that, like negligent homicide, or even, I wouldn't even say this is negligent homicide. I would say this is like manslaughter. You did something and then they ended up dying because your choice was bad. Your choice was bad. That's in the same kind of category as like drunk driving, where it's like you didn't get in your car intending to kill someone else, but your actions were bad and they did. Well, exactly. Lots of terrible choices, but it wasn't intent to murder. So I am sure that, they will probably also put charges on there other than murder so that this can go through. But yeah, it is called the series on Amazon Prime, in case you're interested, Nurses Who Kill. Yikes. It's not a great look for us. Maybe we should, maybe we'll watch and react to an episode of that. We'll have to see. Maxed Out Co says she could have called the MD or NP to come to the bedside and assess the patient if they were really being that wild in bed and they saw, maybe they would have ordered a restraint or a different med. Exactly. Like there's a lot of other ways to handle this, friends, other than going rogue and ordering a whole different thing. It's not what we're supposed to be doing. Okay. So let me switch this one over and let's share really quick I want to share sorry. I threw my sister up on screen really quick. She's like back there just like moderating and chatting. And I'm like, here you are. Let us find the nursing report. Not that. I wish this let you label things differently. Oh, here we go. Found it. Candid Ann said, I would also call the nursing shift supervisor asking for help. Exhaust every single option. Yes. The house supervisor should be notified. This is a Mr. Midwife. Agree. This is a result of frustrated nurses. poor staffing and healthcare currently in the crapper. Yep, that sums it up very well. Um, very, very well. Okay, so this is the nursing hearing. So basically, what happens in situations like this? So she's being criminally charged with murder. That is through the state. That is the state of Kentucky, where a prosecutor who came through one of the state's prosecutors picked up the case and said, "Yes, I will charge this." The police file a report, and prosecutors get to pick what they end up prosecuting. So they are suing her or charging her with murder. Um, on the other hand, there's also a board of nursing, and you also have to go through hearings for your board of nursing. That's like its own little trial type of thing, and they decide what's going to happen with your nursing license. I believe they can also issue you penalties and fines depending on your state. So this is the trial that they held. This is not the big trial with the state. This is the trial that happened with the State Board of Nursing. Let me see. And this happened in, let's see. Okay. Respondent is an RN. So she has been a nurse since 2018. Since 2009, she was a registered nurse since 2018. An LPN since 2007. So she's been a nurse for quite a while, right? She's been a nurse since 2007. That is, I don't really want to talk about that because that's right around when I graduated from high school. So I don't really want to calculate how long that is if we're just being very honest. Okay, let's move on. So finding a fact. Blah, blah, blah. Let's see if there's anything interesting in here that we didn't really see. Received a complaint from the Baptist from the hospital stating the respondent's employment was terminated on April 30th due to a medical discrepancy. So when things like this, 15 years, oh, Lisa, why? And so when this is a case of like, this is what happens if you make a mistake is your hospital usually will report it, especially when it's a fatal error. It's obviously something that we have not seen in other cases that we have covered before, which I will leave linked down below, where hospitals just covered it up. So good on you, I guess, healthcare system for actually saying something. A subsequent investigation by the Board of Nursing revealed the following facts described in paragraphs 3 through 14 herein. I feel like herein is a word I need to start using all the time. On April 30th, 2022, the nurse was providing direct care to a 97-year-old patient who was admitted to the hospital after a slip and fall injury. Yes, we got there. The report nurse informed a respondent that the patient had been restless and spent most of the previous night in the hallway sitting in a recliner. So clearly this has been kind of an ongoing issue. If we know they already haven't been sleeping at night, they're probably delirious at this point, right? After leaving the room, nurse separately contacted the on-duty physician and nurse practitioner requesting meds. They both said no. So this happened in the morning. Then at 7:25 in the morning, the nurse drew out 2 milligrams a vial from the Omnicell, the computer, to be administered to a different patient. At 7:30, the patient's chair alarm sounded, so they were getting up out of bed, and several staff responded to the room. Patient was agitated, attempting to get up. At that time, the respondent entered the room with a 3 to 5 milliliter syringe and proceeded to administer something intravenously into the right antecubital, which is like an IV in the right inner elbow bend area. When asked what was administered, she replied something special. Yikes. Patient was and you should always tell your patients what was being administered. Okay. Don't say something special. That's not good. Patient was placed back in bed with fall interventions in place. Patient became sedated. And when asked again what she administered, the response was something special. Don't lie to your patients, guys. Don't lie to your patients. Don't lie to the other staff. Sometime between 7:30 and 8 a.m., another nurse found the patient with labored breathing and that the pulse ox was not on. So another nurse walks in, sees that they're obviously not breathing super well, and plopped it on. The oxygen level was 76. Again, we want it in the 90s, ideally in the upper 90s, but 76, not so. That's not great. That's not great. I'm trying to think. That's pretty much a that's a worried. You're like, oh, this is like not like, oh, I got up to go to the bathroom and now I'm short of breath. Unsure. We don't know how much she actually gave. I don't know because she didn't document it. She documented it as not given. So we'll see if that comes out in trial. Once the sensor was plugged back in, it was that. The nurse had disarmed and lowered the oxygen monitoring system several times so as not to set off the alarm at the bedside. Again, you can turn the alarm off at the bedside, my friends. You can change the monitor. You can change the monitor to make it so that it is only beeping on the nurse's side. You can always silence it in the patient room so they can sleep. Fun fact for you. 76, I'd be losing my mind. 76 is brain damage. Yeah, 76 like over a little while is definitely brain damage, not good. My perspective on this is probably whacked because our patients would oxygenate it. I mean, in peds cardiac, your patients are oxygenating at like 70%. You're like, yes, it's a great day. You're above 65, but that's a weird world. And in med surge, we had a lot of really sick people. So if they were in the 70s, obviously it's not a great day, but we can usually fix you. We can usually get you back up. But this is in no way where you want to be sitting. No way. Yes, always tell your patients what you're giving them. 76, I'd call a rapid, get oxygen. Yeah. But again, we don't know if this patient was a DNR because if they were a DNR and they didn't even want oxygen, you wouldn't do those things, right? Because you wouldn't be planning an intervention. But we don't know. I don't know if he was a DNR, I'm assuming. And Kendra said a sitter should have been a priority, seeing how uneasy this patient was. But of course, there's never any staff. Unable to medicate. The only thing you can do is check off as often as you can and keep treating your patients. Yeah. And sitters are someone who come and sit like one-on-one with your patient. We like never, ever had them. And this, yeah, we never had them. At approximately 8:30 a.m., the RN discussed with the charge nurse that the patient had been giving something intravenously to cause this decline. So they are taking it very lax, which makes me think that this might be a situation where they might not have a DNR. Mama nurse says intubation stat. I would wake them up first. Friends, if you find someone in their, like, not that 78 is like not an emergency, but if you find someone in their oxygen saturation is 78, wake them up if they're sleeping and see if can you wake them up? If you can wake them up and they pop up into the upper 80s, all right, we're in a lot better situation. If they're not waking up or you cannot get them even when they are awake to get into a better high 80s, low 90s number, yeah, that's a problem. Can you get a reversal agent? Here there would be a lot of, what can we give them to reverse what we gave them? And then if they don't get better, then yeah, you have got to intubate them. That's not good. And if they are on oxygen, even with prone patients, I panic at 76. Yeah. And if they're being intervened with and they're sitting at 76, 76 is not fine to sit at ever. You do not want them to be just sitting at 76% oxygenation. And Rogue said, wait a second. The patient was also found between 7:30 and 8, and the charge nurse was not informed until 8:30. How did 30 minutes to an hour pass before this was considered an issue? Yeah. Yeah. Mama nurse says, with no sitters, the charge nurse should have stepped up and alternated sitting with the patient or even the nurse in question. But what if you can't? You know what I mean? If you have 8 patients, there's no way. And your charge nurse, like when I was a charge nurse on med surge, I took a full assignment. I had slightly less sick patients, which meant only 1 or 2 of my patients was probably getting chemo, or I was only giving blood on 1 or 2, but it's rough. You know what I mean? It's just not realistic a lot of the times to have anyone sit with them, because if they're one of your 6, 7, or 8, or even 5 really sick patients, and you have all the morning meds to give and all the things to get ready for, there's just nothing to do with them. It's a total mess. This is, let me see. Okay. So yeah. At approximately 8:30, so they finally talked to the charge nurse. The charge nurse enters the room and found the patient in respiratory distress with labored breathing and poor oxygen saturation. So this is all at 8:30. A respiratory therapist shows up at 9:08. So what is happening? What is happening here? And why is it taking so long? Again, as many people have said, a rapid response in this situation, even if the patient was a DNR, would at least get people there. That gets the provider there, that gets the respiratory therapist there, that gets a nurse from like an ICU there to help you. And it's the best. So you can call a rapid response, friends, even if you aren't your plan, the patient is a DNR, if depending on what they would like done. It sounds like this patient was fine with being placed on an oxygen mask and a non-rebreather. So clearly, there we go. Charge nurses at my hospital have no patience. That's a magical dreamland. I'm jealous. Is that and then Ermazicon is the antidote for Ativan. Is that carried standard on a nursing floor? Don't think we had it on mine. It was not standard on mine. It was not standard on mine. Respiratory therapists are super busy and short-staffed. Dominique Nicole, that's a very good point. So that's probably why it took a respiratory therapist, who are the saviors of the world, by the way. Respiratory therapists, you can learn like so much from them. Showed up at 9:08. So at this point, the patient was found at 8 with their oxygen at 76, and then an hour later. So that's not good. When I said like 76 is like, oh, let's wake them up. That's like, it better recover within a minute or two. Otherwise, I'm going to be joining everyone else in their panic. Not an hour later. They came in at 9:08. The oxygen parameters, they set the alarm. Oh, so they still didn't even turn the alarms back. They just sat there and they were like, well, let's just keep them off for an hour. Turn the parameters back on. And place the patient on a non-rebreather mask. So a non-rebreather mask is as far as you can go before you go on like more invasive breathing. So it's basically like all the oxygen is getting into your nose. The next step is usually intubation, maybe CPAP or BiPAP, but that's not good. That's more hardcore than the little oxygen thing they put in your nose. Okay. Respiratory therapists suctioned the patient and found grayish black substances that they thought was food or medicine. It's not what you want to come out of your lungs. So if you're suctioning, you're like going in their nose, sucking, the junk out of their major, like their bronchi, bronchus, whatever this, the big one. And you don't want to get anything out of there. So grayish brown is not good. It does sound like it was sitting there for a while, though, if it's already grayish brown, which is kind of odd. And then they did what did they do? They did an x-ray, which showed aspiration of the substances ingested by the patient while in his condition caused the patient to develop aspirational pneumonia. They took them another 2 hours to give the Ermazicon, which reverses the effects of lorazepam. You would have thought that would have been one of the first things that you did, right? You're like, oh, my patient is sedated. They're not breathing well. I did give them drugs that would make them not breathe well. And we should probably reverse that. Wouldn't that be like your first thought? That would be my first thought, but who knows? Patient continued decline. And then the respondent called, despite the rapidly declining condition of the patient, respondent never called for rapid response nor acted with any sense of urgency. They put that in there just to kind of show that they want you to think through it and be like, hey, did you notice? Did you even recognize that this was a problem? Because they're evaluating, do you get to keep your nursing license, right? So whenever you're looking at things for your nursing license, you're always thinking like, what are the safest things? They're like, why didn't you call? Like, why weren't you doing this? Okay, maybe took some time because she didn't tell them until later. Very possible. Very, very possible. It would be very difficult to admit, we might need to give this drug because even though you said no, I shouldn't give it, I did give it. That's true. She might not have admitted that right away if I actually went ahead and gave that. Yikes. Patient's condition continued to decline in the following days. Aspiration pneumonia is very, very, very damaging in individuals who are already fragile, like medically fragile. So like an older adult, because it impairs it makes it so you can't breathe very effectively. And it's a huge reason why a lot of people pass away. So this started a decline, and they were discharged to hospice, which is end of life care, and they passed away 3 days later. Aspirational pneumonia is listed on the death certificate as cause of death. And one of the reasons you can aspirate is because if you're not fully awake and you're fed food, like if you're sedated, you are more likely to send it down the wrong tube. And I think they did say, I read somewhere that they did say that like she had fed him after this event, but I can't find that now. As if this was OB nurse Chelsea said, as if the decision to give the med in the first place was not bad enough. The lax attitude and inability to take responsibility is infuriating. Exactly. If you make an epic error, admit it. Be like, I did this. This is really bad. And you got to admit it. I gotta go. Rogan P said, I wonder if the nurse went off shift. This was given at 7 or 7:30. So when was the shift change? That's a good question. Might be weird. Like, yeah. What are the hospital hours here? That is a good point. Kristen Hager said, hi, ICU ED pharmacist here. Yeah, pharmacist. Thanks for being here. I typically am pretty hesitant to give Flumenzil, can do more harm than good by causing seizures. Oh, well, that's very good to know. Not necessary in this situation, though. Oh, thank you. That is very helpful. Like I said, we did not, we gave such tiny doses of Ativan usually that we didn't need to reverse them. At all. This does not feel like an error. This feels like malice. This is definitely like not an error. This was like, I was told no, and I am going to go and do it anyway, even though you told me no. But do I think she was maliciously doing it? No, I think she was desperate. And she did it to try to calm the patient down. That way. You know what I mean? I don't think she was trying to kill him. I think she was trying to calm him down so she could do her job. Michaela S said, well, I don't think it was murder, but she did deliberately give that med to that patient. Oh, absolutely. But my only thing with saying that is with murder in Kentucky, you have to have intent to kill. So I don't think she had an intention of killing him. I think she had an intention of having him take a really good nap and not be such a pain in the butt at the moment to her. Maxed Out Co. said, does this unit not have oxygen? No one could put her on a non-rebreather and raise a cannula at least until respiratory got there. It's a great question. It's a great question. Why wouldn't you sit there and think, okay, oxygen saturation, 76%. What can I do? If only I had access to something in here. Farm girl nurse doc said this response in the nurse is consistent with someone who has done this before, oversedated a patient with ordered chemical restraint. I fear that was a pattern of behavior that was finally caught. Well, that's terrifying. That's not good. Okay, good. Rogan P agrees with me. Who's a Kate says, I agree. Sadly, she was at her wit's end and made a fatal decision. Yeah, it is. So in this case, it would be what? Manslaughter, homicide, but not murder. That's all I mean by that. Not that like it's fine that she did it. I don't think she meant to kill them. I don't think she was like, I'm going to wake up and like do this. You know what I mean? Hospitals usually do have oxygen right in the room, like Michaela said. But that thought that this is not the first time is, that is alarming. You know what I mean? And that's probably honestly true because it seems like she came to this conclusion quickly. You know what I mean? If she asked and immediately then was able to give it, not good. And Jen 8's name said, not good at all. I've never heard of a nurse dose. That's crazy to me. So nurse dose. Let us discuss for a moment a nurse dose. Okay. So a nurse dose is OB nurse Chelsea. This is the definition of disregard of known risk. Exactly. You can't do this. This is not an okay thing to do to humans. So a nurse dose. If you have been in healthcare for a little while, you may end up hearing about something called a nurse dose. I have been asked to co-sign many a nurse dose, and a nurse dose can be many things. There's lots of memes about it on the internet. That's like a butt of a lot of jokes. And I will admit that after I never I never gave one, but I did not fully grasp the harm. Like I was not like as panicked about them until I then became a nurse practitioner. I was like, oh, this is like this is like a lot. Um, in that like the severity really kind of like I was like, oh, this is like really not good because I started to see a lot of different things. Exactly. Mr. Midwife said a nurse dose is practicing medicine without a license. Exactly. And that really like sank in for me when I became an NP. So what a nurse dose is either, I mean, this is like the most extreme version where you decide that the patient needs a dose of something, even though as a nurse in the United States, you can administer medicine, you cannot order medicine. If a medicine is listed as like as needed, yes, you can give it, but you cannot decide independently that they need it. And a nursing dose can either be giving a medicine that is not ordered. That's a lot rarer. That's what this person did. Or it can be, in this case, you pulled out 2 milligrams of Ativan and the order is for 0.5 milligrams of Ativan. You are supposed to then go to a computer and waste the other 1.5 milligrams of this, right? A second nurse is supposed to be there who signs off and says, yes, I see you squirting the 1.5 milligrams of Ativan out into the kitty litter. Clearly, we're not going to be diverting it, which is like pocketing the rest of it or pocketing the whole thing, right? There is, there's a whole lot of issues with a lot of things. So, a nurse dose would be like, hey, they only ordered 0.5. I really wanted 1 milligram or even 2 milligrams. So can you just come co-sign this for me real quick? Like, and they're like, oh, sure. Like, how much do you want to waste? And you're like, well, like, let's just say I'm wasting 1.5, right? I've seen that happen a lot of times. Like, let's just have this happen this way. Or, they ordered, this is this, you're in the med room and the person will be like, oh my gosh, can you believe they only ordered 0.5 milligrams for this patient? It's like over there and like, blah, 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 blah. The person's like, that's fine. I'll just co-sign. Or if you have someone who comes in, they're like, hey, can I borrow your finger? Right? Because on our Omni cells, you just had to hold up your finger and that counted as your co-sign. Can you just co-sign this for me really quick? Or you can do it at the bedside just by scanning your badge. Can you just co-sign? Okay, but boop, you're in a rush. Right? Always look at what you're co-signing, friends, and always watch the waste. It's not the cool thing to do. I will tell you, it is not the cool thing to do. It's not a good way to make friends. But having worked, I've worked with people who have had some serious difficulties in their own life by either diverting it or giving nursing doses, and it is not worth what happens when you realize that you are the person that was co-signing on all of these things and how the meds got out there. So basically what happens is they order 0.5, someone else wastes with you or just scans their badge for you to co-sign the med that you wasted and you give more. There's jokes all over the internet about nurse doses, but they can be really, really harmful. And either to the patient if you're giving them more, or if you are taking that and doing something else. If you are approached by someone who is asking you to do that, you can either just say like, I don't feel comfortable doing that, something like that. Just figure out whatever is going to make it the easiest. Nurse Connor, I think, had a thing he was talking about this on the other day on his TikTok, and he said something like, oh, like, I'm not going to be like, I'm not comfortable with that. I'm not going to be your person for that, kind of to like make it clear, like, please don't ask me that again. But that is what a nurse dose is. Nurse dose, very, very different from, exactly. Nurse dose, like Lisa said, is nothing like PRN. PRN is as needed. That is a physician, a PA, or an NP saying, hey, I'm going to write this. You don't have to give it to the patient, but if they need it, you can. And sometimes they'll even write it on the sliding scale. They'll say, hey, here's a pain medicine or here's Ativan. You don't have to give it, but if they need it, and you can decide as a nurse if they need 0.5 or 1 milligrams, right? This is talking about them writing a specific order and you saying, I'm going to give them more. Who's going to know? Let's just do this. Not good. Mr. Midwife says emergency medicine, ACLS, life-saving stuff, terbutaline, APAP, Motrin, Start and IV, Kleenex. I'm great with that, but I draw an absolute line at controlled substances. You need my order. Exactly. So another thing here is what happens a lot in healthcare is nurses will just do things. And this is a tricky one because we do a lot of things without an order. I would say I don't give controlled substances necessarily without an order. But I mean, even then, I guess that's not true. Sometimes we did, like if a patient was having a seizure, sometimes we would go, you knew that's what they were ordering. This is also where it starts to get tricky with like, what do we do now in terms of liability? Because we used to just, in an emergency situation, you're going and you're giving the emergency med and later someone will write for it. Nurses do a lot of other things without an order because then someone you're like, hey, I went ahead and did all X, Y, and Z. I've already done all of this. Can you write an order for it now? And the provider will go in and back chart for you. So then they'll order the things that you already did. Don't do that with controlled substances, friends. That's a hot mess. Michaela S says there's a reason nurses are taught how to order medications because it requires understanding different doses and medications, how they could affect a person. I think it meant are not taught. Aren't. I got you. That's just a whole different thing. My license, my responsibility. Exactly. It's not, that's why there's, that's just a very different role in healthcare, not one being better than the other. Just very different. So just be conscious of that. Siri just brought up something by David Bowie. Sometimes Siri just pops up and she's like, yeah, this is random. Then I'm like, I don't want that. Mama Nurse said, but she still charted it as not given. So if she did that, that would cause a discrepancy in the system. No. Yes. Exactly. So what happens is if you chart not given, then the the charting system is going to know, okay, then I expect you to be able to have a paper trail somewhere electronically of you didn't give it. So now there needs to be a waste of 2 milligrams of this medicine. Right. And that, didn't happen. Depending on your unit though, I know some units that were so busy and so many meds were being pulled all the time that at the end of your shift as a charge nurse, at least when I was a charge nurse, you went to all your medicine things and you would go in and you had to sign in and say, are there discrepancies? AKA the medicine machine could talk to the computer and say, are there things like Mama Nurse just said? Are there any open cases where it was like, you pulled this out, but you didn't give it? Or you pulled this out, but you didn't waste the extra? And it will spit it all out to you. They'll give you this report and then you have to go and track down the nurses and being like, hi, I have something saying you pulled out 2 milligrams of Ativan, but then you marked it as not given, but there's no waste. What happened to this here? And then you have to go through and clear it all up with the computer, give it reasons for what happened, or go and have people waste the stuff so that it's in the computer and there's a paper trail. In the perfect world. And usually as a charge nurse, I could not leave until all my discrepancies were rectified. I don't know what different policies are, but I've also been on units where people just gave the computer weird excuses. So if you worked on a unit, obviously I know nothing about this unit, but if you worked on a unit where it was very normal to just tell the computer, oh, this is fine, I figured this out, they dropped it, it fell on the floor, blah, 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 all the different things you can select in the Omnicell to say I can't waste it because it fell on the floor, got eaten by a tiger, fell out the window, whatever the options are. I think really the only one is fallen on the floor, and they just they just kind of go in, they give it an excuse and they move on. You could get away with something like this. You know what I mean? So I don't know the culture of that unit, which also makes it very important to just figure out what kind of unit you're working on. Okay. Yeah. Renee Westner said, and then after you fix it, someone gets a random drug test on your next shift. Yeah. That's when they show up and they start doing random drug tests. My union actually did not allow us to have random drug tests, which I think was actually dangerous because there were a lot of people that permanently exited at my hospital using medicines they had diverted through things like this, and probably would have benefited from drug testing. After the damage was done and doctors found out, does anyone know if the doctors that they had given high doses of glutathione to help mitigated the sedative meds and improve respirations? I don't know. I do not know. I'm assuming all of that will come out. So this is just the nursing investigation, right? So this is just what the board of nursing came through and they removed her nursing license. In case that wasn't clear, they took away her nursing license. They said, you cannot do this. This is unsafe. You have done some really, really misused or inappropriately managed drugs, placed in the custody for nurse management, falsified or and made incorrect entries, and failed to make essential entries or essential records. So you didn't chart it. You willfully or neglectfully acted in a manner inconsistent with the practice of nursing, and you are unfit or incompetent to practice nursing by reason of negligent or other causes. That is what they concluded in the nursing report. But this was just looking at what did the nurse do. They didn't go into all the other, like what else was given, the whole case of it, right? They weren't looking at why did it take respiratory this long to show up? Why wasn't this med given? Why was this happening? They weren't looking at that in this case. When the board of nursing looks at it, they just want to know, are you safe? Can we let you go back out there? And the answer here is please don't. Please do not. Please do not. No. Who said Kate says, I feel so old. When I left bedside, we still took turns carrying the keys to the narcotic drawer and everything was on paper. I lived in that. I worked in that era. By the time we had keys in to none of our meds are, when I started at my hospital, we had paper charting, but the computer, we had the computer or the medicine cabinet was digitized and we were moving over. And yeah, I know what you mean. When we moved over to the computer, we were all like, oh my gosh. And Who Said Kate said, my nursing career, I've seen more than one nurse or physician leaving the floor in handcuffs and not the sexy kind. Yeah. Yeah. This is, with how stressful healthcare is, there is a lot of substance use by hospital staff. I think nurses are some of the people I think the amount of alcoholism in nursing, I mean, it's just staggering, right? Just absolutely staggering. The amount of substance use in healthcare because of how stressful it is, how burnt out you are. And yeah, Lisa says in rural nursing, there's still keys and paper. Yeah. And in nursing homes, I know nursing homes still use keys and paper. You have to get an actual key to the narcotic cabinet. But yeah, so that is, that's the situation. It's sad. I feel very badly for this patient, for his loss of life, for the patient's family. We can continue to kind of follow the case and see where it goes. But mostly I just wanting to kind of highlight that this happened, what we can kind of learn from it, that nurse doses are not okay. And yeah, don't do this, friends. We kind of mentioned some alternatives in it. And this is just, oof. Oof. Those are my thoughts. Very eloquent, I know, but just oof. Who Said Kate said the latest statistic I read that up to 10% of nurses are either diverting, addicted, or both. Yikes. And a lot of that is, hey, I'm going to draw this medicine up and then I'm going to waste it. So I do everything appropriately. When I go to inject it, I'm injecting saline. I'm not injecting actually any medicine. And that is really common. And it's really, 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 really sad. It's really sad. We actually had an abandoned part of the hospital that was known for everyone. People would just go over there and do all sorts of stuff. Very sad. Sam said, I live in constant fear of a situation like this. I have open orders for Versed, Ativan, Dilaudid, fentanyl, Halidol, Benadryl, and morphine. That's a combination. Ooh. That is a terrifying statistic, Matthew Ives. My MDs have no idea how to run a code. It's all the errands when it goes south. So that's pretty, in a situation where there's a lot of if you're in an ICU, especially, usually I would say it's the nurses who are the ones that are really running it. And the physician or the resident is the one kind of in charge. They're not navigating exactly what everyone is doing. They're more keeping track of the whole situation. How many rounds of this have we given? Where are we in terms of reading the strips? Do we have a heart rate? Where are we here? But usually nurses kind of run the codes in terms of drawing up all the stuff, knowing what they're going to order. Yeah. Lisa said, I do not understand how anyone could want to take something that leaves them out of control of themselves and their actions. I mean, I think that's an escape for a lot of people that I think unless you've been there, I don't ever want to cast any judgment on people who please don't use substances to try to avoid things like that. But I understand why people do, right? Because they just do not want to exist in the way they are right now. You know what I mean? Um, uh, yeah. And that too, people think they're in control or they don't want to be anymore. You know what I mean? That it's, yeah, disorders don't always make sense. Yeah. The way your with addiction and substance use, it is a disease and it is your brain. Your brain can convince itself of a lot of things, right? And your brain can also tell you like, hey, this is fine. We're coping well. This is great. Addiction is a coping mechanism, like Mr. Midwife said, and it doesn't make sense. Yeah. Desperate people do desperate things. You can't look at it as someone who is thinking clearly, and look at it and, be like, oh, well, this, why are you doing that? Because it's not a rational thing, that someone is doing, but when you're in it, that's just a huge outcry of someone that is being in a lot of pain. Greatco said, joining late, but could these instances be avoided more often if a reason or non-condescending explanation is given to the nurse when their med or intervention request is denied by a provider? I don't know, maybe. I mean, I think it would help. I don't know if she had an explanation. I don't know if when they said no, we're not going to do this because we're worried about their kidney function. No, we're not going to do this because of the risk of, these meds in older patients anyways. No, we're not going to do this because we're worried this is going to make them more confused. No, we're not going to do this because they are admitted for a fall and I want to assess their mental status. I don't want to give them a sedative. That's not going to help. Like, I don't know why if they explained it. I think it helps. When I tell people no, I like to tell them why. Hey, I'm not going to do this. And it's not because I just woke up and I'm cranky today or I haven't had my 7th cup of coffee. This is why. I do have a good solid reason behind it. That doesn't happen very often. Usually people just say yes or no. I think it's helpful. Would it have stopped this? I don't know. But that's also a very good practice of if you're not going to be able to do something is explain why. You know what I mean? Michaela S. said, I worked with a nurse that knew another nurse who stole medication from nursing, that worked with for over a year. It took over a year to build a case to fire them. Ooh. Liz, you don't need coffee. I don't need coffee maybe at 10 at night, but in the morning I need like a lot of it. a lot of it. Because my children I was not aware that like my children would not sleep through the night until I don't know when. I have a 5-year-old. She has not ever slept through the night once, ever in her whole life. Ever. I was not aware of that when I signed up to be a parent. No one told me that. I thought, I was like, oh, it's just a baby thing. It's not a baby thing. Wait, give Liz a nitro cold brew and put her on camera. That would be amazing. Yeah. Mr. Midwife, is my sister. If you've ever seen her in the morning, she needs coffee for the sake of the people around her. It's true. I don't really speak. This is me like in the morning, put on a sweatshirt and I come downstairs and I look like this. I don't really speak. I just kind of like, I glare and I look down and then eventually people caffeinate me. Nitro cold brew is amazing. Amazing. What could go wrong? It's not a baby thing. My 8-year-old is a natural future night shifter. Great. So this gives me zero hope. I was like thinking maybe this year it'll be fine. Maybe this year. No. Farm Girl Nurse Doc. I am presenting a CNE about addiction among professionals in healthcare next week. It's free. If anyone's interested, I could share a link. I would love that. Absolutely love that. If you could send that to me, that would be perfect. I'll put my email in here. And then I will link it in the description here and I will share it out on Instagram and all the things. Who said, Kate said, it will come, Liz. My oldest daughter didn't sleep through the night till 5 or 6. It's hard and we'll get better. Also, second opinion, you can go to bed. You've done an excellent job, even though I threw you up on there. But yeah, it is a huge, huge issue in terms of especially I feel like in the last few years, substance use in substance. I'm not laughing at that situation. I'm laughing at neuralia, disgruntled, tired mom noises. And it's literally that. And it is exhausting when they don't sleep. So, yeah, a horrible situation in terms of medication diversion, substance use, this horrible situation when our healthcare system is in such a state that we can't provide non-illegal pharmacologic interventions for people who just need, you know, a safe place to get better, as this patient did. Yeah, I think it also calls into a lot of different things of what are we doing when we admit, this is a very different right turn, but I think it also opens up different conversations of like, what are we doing admitting 97-year-olds to the hospital? Like, are we really benefiting them in that case? I feel like I've seen a lot of, not that they don't deserve care, but after a fall, you know what I mean? Like, it really stinks that our only societal option is to admit someone to a hospital when they're 97, when really what they need is someone to sit with them for a little while and make sure that they're okay, explain their, like, if they're not okay, what's happening here. But are we going to put them in a hospital where they're not going to have enough care, where they're going to be confused and isolated and, at risk of infection? I don't know. It's just, that's a whole different conversation. You know what I mean? Of how we care for older people or sick people even, but especially older people in our society, is we medicalize aging, as we medicalize many things. And I think we could just do a whole lot better. And this is true. Absolutely. Sometimes the families push to have the 97-year-olds sent to the hospital. Absolutely. I have had families absolutely push to have 97-year-olds in the hospital. I have had 97-year-olds who are in there, like they broke a femur. And I mean, they're like up and walking, like, afterwards, not with their broken femur, but they get it fixed and they go. It all depends on the patient disposition, but I'm just saying in general, like, I think we could do a lot better about that. Rural nurse asked a doc why we were admitting someone. And he said, he's 95. I said, that's not a diagnosis. Exactly. Yeah, exactly. We don't just admit people because they are older, and often older people do much better when they receive care in place versus taking them out of it. Yeah. Oh, yes. Michaela S. I follow a YouTuber named Jessica Kent. I really like Jessica Kent. She has a lot of good content about addiction, as she is a former addict and now has a degree in prison system support systems. She has a lot of really, really great content on this. I agree. I will try to link her content if I remember. I will try to remember. It has, let me see. Families want 97-year-olds to have surgeries, the whole 9 yards. Yeah. I have had, I like your screen name, Roar Dinosaur Gur. Yeah, a lot of families want their 97-year-old grandma to have like a full code. I'm like, we do a horrible job at explaining what that looks like, what the long effects are, what the outcomes are. We do a whole lot of things to bodies that is really rude and cruel, in my opinion. But yeah. I have a 102 walking. Yeah, I have literally had one of my favorite patients ever in med surg was this woman who was, she wasn't even on our floor for very long, but she was 103. And she was, she had so much like kyphosis and was so shrunken. But I forget, I don't even remember what she was admitted for, but she like dominated our unit. Everyone was like kind of terrified of her, but in like a awe way, because she just like was like up and moving, and like she was 103 and she seemed like she was like 63. It was very impressive. But yeah, you can't judge all, definitely some people who are 103 should be in the hospital and have all the things if they want them, but dang, not all of them do. Sometimes, Michaela said, sometimes what the patient wants isn't what the family wants. Absolutely. Just because they can't accept that they're ready to go. I have done in primary care countless meetings with patients who, after we had the DNR conversations and whatever, yada, yada, highly encourage you to have all of those conversations with your family members, your patients, all of the things. And then they would come back in and we would literally have an appointment that involved nothing medical. It was just us having a conversation, me explaining to the family, like, this is what this person wants or does not want. And this is why. And we all need to get on the same page. They have a document so that this will be carried out, but like, this is why. And a lot of therapy for like family. I'm like, this is not my job, but I will do it because primary care does all the things, but what the heck? uh, Noralia is taking a very extreme approach. I never want to be older than 30. Cut me off there. That sounds like my husband. He's like, once I pass 40, just don't even bother. I'm like, well, can we please reevaluate? Like, please, please. And yes, let me see. Who said Kate said, I'm so grateful for my fellow hospice nurses who helped with my 90-year-old dad. They helped us immensely. That's awesome. Hospice nurses are the absolute best. I also see a lot of chat in here. Melody. So if you, yes, do follow, I haven't made a formal announcement because I didn't know if that was like my space to announce it. If you have followed the channel for a little while, we had a panel member for a little while named Melody, and she was a lovely human. She gave a lot of a patient perspective. She was a therapist, but she also had a lot of chronic healthcare conditions. And she did pass away at the end of, I think, August. It was very quick. It was very peaceful from what I've been told. And she went how she wanted to, like feeling like she was in control of the situation, which is good. She got to kind of go and do it on her own terms. I don't have all the details of the situation, just kind of like she clued me in on kind of like, I am in contact with a few people that know more about it. But yeah. So she was an amazing person. She was a really lovely person. And I think this sums it up well. I'm happy for Melody. She's finally free. Yeah, she was she had required a lot of medical intervention in order to be here. And I think she was just very, very done. Very, very done. She got to go to Europe. She was in Europe. And it was oh yeah. I was like, how do Rachel mentioned it? I forgot. I was going to mention it in a much more tactful way, but this is totally fine that it came up here. I have a whole video that she and I recorded together a week before she actually passed away that I'm going to put up at some point as a fundraiser. She had a charity in mind that she wanted the money to go to that was raised in the event that she did pass away. I just haven't gotten into a space where I was like, ooh, like I'll put this together well, like, cause I want it to be done well. You know what I mean? And so that will be up eventually. And that's, yeah, I feel I probably should have brought it up earlier. I just didn't know how, you know what I mean? Like it's a bummer. Not that I'm all up like, I just didn't know how to bring it up. But yeah, so that is incredibly, incredibly unfortunate. And Mel, I don't think, I don't think like it's totally okay to have all the feelings about it. You know what I mean? We kind of have like our little group here, and so you get close to people and like, I know it's like internet friends, but, it affects you a lot. You know what I mean? So yeah, she was a wonderful, lovely human. I'm exciting for, to be able to share what we kind of like what she put together. She shared a lot of like the work that she's worked on. It was a really like cool conversation. So I want to like put it out there well, if you know what I mean. And yeah, so there'll be like a fundraiser. It'll be like a charity stream type of thing. And yeah, so she is no longer in pain, which I am happy for. I'm just sad for the rest of us because she was a cool human, really cool human, really, I think someone said like feisty. She was very feisty, and gave a really great, she was very into like advocating for people who needed to be advocated for. Yes, I loved her feisty nature and zest to the voice of the people. Yeah. And so, yes, so sorry it kind of came up in that way. But that was a book, a past panelist who has since passed recommended a wonderful book called Medicalizing Age, called Being Mortal. Yeah. And I think that'll be a really good, cool, a good book to read to help understand a lot of that stuff. So maybe we should start a book club. That would be quite a book to start our book club with, but maybe we should have a book club. Who has time to read? I don't know if we're there. So yeah, totally fine to, like, who said Kate's very sad to hear about this. Yeah. I think it's really hard also when it's like an internet person, you know what I mean? That you don't like, and then you feel like, oh, I didn't know them in real life, but like you knew that, like, that's just kind of, I feel like, I wonder if there's going to be different like grieving types of things. Cause you almost feel like in grief, you know what I mean? Like that you need to actually like have met the person, you know what I mean? Like in order to have like those relationships. And it's just different, you know what I mean? Cause obviously you don't. I think grief, however you're feeling, is absolutely valid. Sorry to throw that on the end of the stream. But yeah, that is the news there. I will let you know when, yeah, we are still a close group here. She was family. Yeah, exactly. We're like a tight little club. I will say I like your optimism, Chad, that one day we will be a giant club. But yeah. I thank you for telling it. Yeah, I'm very sad, but glad Melody is at peace. Yeah. She was very, 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 very okay with it. I will say that she was very done with. It's got to be exhausting going in and requiring. She was in the hospital 4 to 5 days a week, getting like infusions and all these types of things. She couldn't do the things she enjoyed in life. I think at a certain point, you get there. Michaela said it would be great to have now we need to find a person. Yeah. If anyone has a patient perspective, that was really appreciated. Melody, in case you're totally unfamiliar, like, who is this person? She was someone with, she came on a lot of our panelist discussions, and she provided, a perspective of someone who has been not on the healthcare side, but like as a patient, who has been greatly involved in healthcare, which was very, very helpful. So if anyone out there, you want to like chat and see if maybe you would ever like to sit in on some panel discussions that we have, that would be great. Like, cause I think that was a really one of the things that, she was great at a lot of different things. And that was one of the things, was really opening your eyes to some of the things that you didn't necessarily realize. She talked a lot about just simple things, when you're in a hospital bed, hey, don't call me like patient 39 or like bed 37. You know what I mean? Hey, when you're doing this, like, phrase it like this, don't phrase it like that. So, yeah, there's that. I am sorry to hear it as well. Yeah, she had great insight. She had really great insight. For sure. She was also really, really, really funny. And when she got mad, she was like so funny, which is like bad to say, but it was almost like worth getting her worked up, because then she just got like, she was like so cheerful, and she had such a high pitched, like happy voice. And she was kind of like, she was always like, so like uppity and like happy. And then she would get mad, and she was just like a little, I don't know, like an angry little chipmunk. It's always like, oh my gosh. Your rage, go rage. Exactly. So Jay Michaels had an interesting perspective, is the nurse who is also a chronically ill patient, for sure. That's why we let Scott be here. That's really the only reason we allow Scott. He might not be allowed anymore, as he is not here. So we should have a book club. I'm down for it. Davis's Drug Guide for Nurses is a real page turner. I personally like Patho. It puts me right to sleep immediately, or theory. There. Oh, Jay Michael, I'm a full-time RN and cancer patient. I am sorry you were dealing with that. I don't know if I knew that. I'm sorry. Well, hey, email me. Let me know if you ever want to be on the panel. Did someone say Scott? Scott's not here. We can talk about Scott as much as we would like. And Neuralia, I'm always up for the trans patient perspective, but I never live up to her insights. Hey, we're here for all of it. So We're here for, like everyone brings their own thing too, is the huge thing. Everyone brings absolutely their own thing. Yeah. Mel said, I get the being done thing. And if things hadn't turned around for me, likely would have been decided the same. Having done it for several years, living in the hospital is indescribably exhausting on many levels. Mel, I'm very glad it did turn around for you. But yeah, I have watched a lot of people live in hospitals for a very long time, especially on a cardiac unit, waiting for like heart transplants or things like that. And it is observing it looked indescribably exhausting. I cannot fathom living it. Cannot fathom. Renee said, I went into healthcare due to my history as a patient. I have lupus, but I know it helps me as a provider. I'm sure it makes you so much more compassionate. Like you just get it on a totally different level. Totally different level. We need another parent note, this time from Scott's dad. I need to dig up. So maybe as a discipline of some sort. I don't know if I'm supposed to share it. I have a picture of Scott in drag that he sent me. Well, he sent it to me. So we will be sharing that on Friday during our panel discussion. We will be able to look at that and be like, well, I wasn't going to share this with everyone. Now I am. Maybe he secretly wanted me to show it. You say Scott's name 3 times in the mirror, he appears. I think poor Scott is very stressed. Very, very stressed about the whole situation, about patho. Very stressed about it. Chelsea, OB nurse Chelsea is choosing to come here and let me distract her to get away from patho. Scott's obviously choosing the much more boring option of studying. He's given up texting me though about different. He's like, how did you do this? Because he would text me and he's like, oh my gosh, like Liz, how did you deal with this in patho when you were trying to get through it? I'm like, Scott, I didn't really study. Like you. Like I watched a lot of YouTube videos and listened to podcasts and like crossed my fingers and hoped that I would be fine. And then I got a C and I was thrilled. He's like, I want an A. I'm like, yeah, we wouldn't have been like friends in school, Scott. So don't keep asking me what I did because he's like, how did you read all the information on theory? I'm like, Scott, I didn't even buy the theory book. He's like, I don't understand you. Like, this is why you come on the streams because we are not the same human. Exactly. Share everything when he is not here for punishment. Yes, we do love our nurse Scott. That's why we're making fun of him. I should be studying patho too, in particular immunology. That sounds awful. Absolutely awful. The world needs overachievers. You know what I mean? If all of us were just like, I'm going to skate by humans, this would be an interesting world. I'm really glad there's like type A, really, really glad there's type A people who desperately need to be overachievers because we wouldn't probably have a lot of the innovations that we have. The world would be very messy and chaotic. I would not want a world of people like me. That makes me terrified to think about. Oh, absolutely terrified to think about. Don't like that. Yeah, Neuralia, we would be totally happy to have you. Just email me in all caps. It helps me see it because again, I'm not a very organized person. And then Kate said, kind of going back to the conversation, back to like the actual topic, that just because you gave someone a medicine doesn't mean that that was their cause of death. No, for sure not. But that's, I think, probably going to be evaluated more in the court case. This was just can't be a nurse anymore if you are giving drugs that are not ordered and you're stealing them from other patients. Okay. And then you lie about your documentation. That's not good. I didn't study either. Chad, we would have been friends. We would have been friends. Neuralia, email me here. nurselizyoutube@gmail.com. And I'll add you to the email list. So basically what happens for panelists is there you go. Prospective panelists email nurselizyoutube@gmail.com and add panelists in all caps or I might get lost. You get put on a list and basically you get an invite whenever lives are like panelists' lives are going up, essentially. Kate said also, didn't she administer a medication that was not ordered by a physician as well? At least feed him a meal while he was at least alert. That sounds like an awful decision. Yeah, it was. She made a lot of really poor decisions. This was not a good thing. Let me see. Thanks, Mel. Resend it. Perfect. Rachel, be on the lookout for it. All right, team. Michaela said, and just because someone gets a C doesn't make less of a person. In my opinion, it's a person. It's that a person better because they know how to fail and thrive. Yes. See, that's what I always told my nursing students, right? Um, that is what I've told my nursing students so many times when they came to me and they were like, I'm a little bit worried because I'm like not getting A's. I'm like, my friend, I never got A's. But it taught me that, I can overcome difficult things. I was like, the people who get all A's, they're going to pop out into nursing life and be like, oh, wow, this is a lot. I'm failing for the first time because you're going to fail when you're a new nurse, you're going to fail. And I was very used to it. Yeah, this is just like school. This is fine. We're all fine here. At my school, C is an F. That's how my school curved it too. In grad school, like a C, like a C was really like in the 80s. It was the stupidest scale ever. Stupidest scale. Sophia, thanks for being here, friend. Missed you. Oh my gosh, I have 3 tests on Thursday. I'm fine. This is fine. That's not fine, friend. I think isn't there a rule in most schools where you cannot have 3 exams on one day? At least in my school, like you could apply to have one of them moved to like take it on a different day if you had 3 on one day. I think you could only have 2 on one day. There's way too much information to ace everything. Having a good foundation is all I may move for until I can get on the floor. There we go. We need an 80 to pass. Ooh. Ooh. I think we had to have an 80 in the class, to be fair. I think we had to have 80 in the class, and I essentially relied on, because I'm not a good test taker. I'm not good at focusing. In case you can't tell, I fidget. The ADHD is strong. I cannot sit and take a test. I get bored. I can't focus. I can't read things. So I don't do well on tests, but I can make up for it in like essays. And I can make up for it in essays because I would write the content and then I would pay my sister to help me make it sound more eloquent. How I got through nursing school. In a summary, it's not good. That's why when Liz rules the world, nursing school won't exist as it is and will drastically change. Exactly. We're going to be pretty much going back to the way that diploma schools do things. We're going to be doing a lot of things in the hospital, friends. We're not going to be messing with any of this stupid textbook crap. Exactly. Shiny squirrel. I would be like sitting there, like coloring in the bubbles. I'm like, oh, look, I can like shade this one and left to right. And I can look at the pattern this is making. This kind of reminds me of this. Let me analyze the pattern. And now I'm going to, even though I'm very sure that this answer is B, it doesn't line up in this other pattern. So I'm going to change it so that the lines are straight on my page. Yes, me feeling my IV bag of cold brew in at 8 a.m. Exactly. Oh, okay, friends. Oh, good luck, Mel. One of my classes requires an 85 to pass. I don't think I'd pass. Thankfully, it's more of a writing or presentation based one. Okay. And I can do a presentation. I can talk. I can talk my way out of most presentations. I can be like, we can circle back here and let me make some sense out of this. Either that or I'm so all over the place. Probably similar to this YouTube channel where I'm so all over the place. People are watching and they're like, I don't even really know what's happening. I don't understand the point here. But I also can't stop watching because it's kind of a train wreck. I want to see if she can get back. Exactly. They'd pass me on a presentation just to get me to stop talking. That would not be shocking. That would not be shocking at all. Who said Kate? Oh, thanks. Don't forget to smash that like button on the way out. Yeah, if you do compressions on the like button an odd number of times, it does save the life of the video and it tells YouTube, hey, this was great. Other people should watch it, which in turn makes me very, very happy. Other ways, if you like to support the channel, you can join my email list. That's exciting. You get random handouts and random thoughts. You can become a channel member. That has some random fun perks. More coming later. And is appreciated. You can subscribe. You can like. You can share. You can just chat. All things accepted and appreciated. Very appreciated. All right, friends. I am told that there's a episode of the Great British Bake Off. And yes, for channel members, we have a reaction video coming to you guys soon. This is news to me. I'm sure she has informed me before. I forget what I'm reacting to, but it'll be there. I can never remember how Liz says it. Just do the YouTube things. I appreciate you. Apparently the Great British Bake Off has episodes and I need to go watch them. Is that true? Oh, yes. Oh, that's what she meant. Okay. There is a reaction. I do remember. She's like, I texted you about this today. I'm like, it was not in the last 5 minutes. I don't remember. All right, friends. Thanks for being here. I very much appreciate you. Thanks for joining this conversation. It was certainly, that was all over the place. I hope that you are taking care of your mental health. Don't give nurse doses. Just do what the orders say. Okay. Question it. Go up the chain of command. Do not take matters into your own hands. This is very serious. Like, you don't, vigilante justice does not belong in healthcare. Okay. It belongs on the road and it's called road justice. Okay. That's when you take it out on other cars who are tailgating you or otherwise doing shenanigans, and you team up with the person next to you and you're like, yeah, we're going to just like block this person from being able to ever pass us. Also, probably don't do that because bad things might happen to you. Anyway, thanks for being here, friends. I appreciate you. I hope you have a beautiful rest of your night. Go watch some Great British Bake Off. I hope Joe wasn't teasing me when he said that that was on an option on the table for later. He was like, oh, this is on. I was like, it better be on. Please do remember that you, my friends, are not alone. You are more than enough, and you can do all the hard things like patho and all those stupid tests you have to take. Till next time.